to disclose. Craniopharyngiomas remain a major therapeutic challenge, even to the most experienced of neurosurgeons. But why is that the case? So we know that.
Want to go to a full screen view?
Yes. So craniopharyngiomas remain a major challenge to even the most experienced neurosurgeon. The question is why? Well, we know that most patients will survive the disease as well as our attempts to treat them for a long time. But we have difficulties in predicting which patients remain virtually symptom-free for decades without any treatment, which ones may be severely debilitated, and which ones can be safely cured with surgery alone. And because morbidity rates for the visual loss and hypothalamic dysfunction remain high, the management has a long time been controversial. So here, a typical clinical vignette. This 42-year-old French teacher came to me from an outside hospital and presented initially with memory problems and some increased thirst. Her history of present illness showed some double vision with minor car accidents. She was more forgetful for a few months, had some increased thirst and urination, and was somewhat fatigued. Past medical history showed bipolar disorder and ADHD, and a polycystic ovarian syndrome, and some psychotropic home medications, but family history and social history was rather unremarkable. At the outside hospital, she was worked up after a minor car accident in the parking lot with the question of, is she confused, a bit changed in her mentation? And by report, her ER exam was normal, and she had also normal labs. However, in the United States, when you have a car accident, most people get a CAT scan, and imaging revealed a tumor. This is the initial picture from the outside hospital that we can look through the internet at. So this showed a large suprasellar mass of about 4 by 3 centimeters with some cystic and some solid component. Here you see the cystic part and the solid in it. There was no evidence of hydrocephalus and no calcification. So what's the differential diagnosis here? And you immediately think about, could this be a pituitary macroadenoma, a craniopharyngioma, or a Radke's cleft cyst, which are all the same ballpark, or maybe a metastasis, because that can mimic anything. And then there are rare other tumors like a colloid cyst and so on that can also show up in this location. So we requested an MRI scan, and the initial MRI scan was done with and without contrast. And you see in the T1 pre-contrast, T2, the cystic component with the solid part in it, which is vividly contrast enhancing. It sits at the floor of the third ventricle, and on the gradient echo scans, there's no hemorrhagic component. So that makes you think about craniopharyngioma. But what should not make us think about craniopharyngioma in this setting? Well, the MRI scan shows a supra and paracellular tumor with a solid and cystic component. In CAT scans, you see calcifications in more than 50% of cases, and that is more so in the pediatric population. And clinically, patients often present with long-standing hypopituitaries and occasionally diabetes insipidus. Craniopharyngiomas are benign disease, but rare disease. It's only about 2% of all brain tumors in a mixed population with an incidence of about 1 in a million, which is equivalent to 350 new cases per year in the United States, which also tells you that none of us see a lot of this, which tells you there's a lack of experience in all centers. There's a bimodal distribution, about 40% in the pediatric age group and 60% in adults, with males and females equally affected. The pathology is interesting because you usually see a well-circumscribed lesion with a dense fibrovascular stroma interrupted by well-differentiated squamous cell epithelium that forms almost skin displaced in the middle of the brain. This is how it looks on the higher magnification. You see a nice basal cell layer and then progressive differentiation into keratinized cells. So this is a very typical appearance. Now, cytokeratin expression differentiates the main culprits of our differential diagnosis. Craniopharyngioma, Radke's cleft cyst, and pituitary pars intermedia can be differentiated by craniopharyngioma being negative for cytokine cocktail 8 and 20. Here you see a picture where the stains on CK8 are negative in the craniopharyngioma population, and in CK20, where this is positive for Radke's cleft cyst and positive scattered for pituitary pars intermedia. Now there are two subtypes. One is the adamantinomatose subtype, which is the larger number, usually arising from teeth rests and usually in children. This is a rather poorly circumscribed type of tumor. and contrasts heavily with the papillary type of craniopharyngioma. That is a smaller group of them, usually occurring from mucosal rests, occurring in adults in a well-circumscribed tumor, as you could see in our sample. The origin of craniopharyngiomas has a classic theory that these arise as embryonic malformations from Barrett's cleft pouch. And modern theory has shown that in mouse models, the adenomatous, the pediatric version, can arise due to paracrine activities of beta-catenin mutated cells inducing tumor stem cells, whereas the adult version of craniopharyngioma arise via metaplastic transformation. That's why they are more differentiated. Now, there are a couple of classic clinical issues in these patients. Typical presentations are a combination of visual, neurological, and cognitive compromise, but we see a lot of pituitarism, hypopituitarism in 90% of patients, hypothalamic disorders with obesity more than 50%, diabetes insipidus in 80%, and thermoregulatory and heart disease, as well as sleep apnea. There's an increased cardiovascular risk with women more affected, causing arrhythmias, and likely this is from a combination of hypogonadism and exposure to sex hormones. There also is reduced bone health, all translating in decreased quality of life. Now, our patient was transferred from the outside hospital with the label of tumor, and again on arrival, the ER attending the neurosurgery team and even the endocrinologist said she has a normal exam. But if you look at this picture, this is a large tumor sitting in a delicate spot, so it's unlikely to be truly asymptomatic. So don't be shy in calling in the ophthalmologist to say, I need an examination here in the ER, and you repeat the exam and admission labs. So here the urine spectrogravity was 1020, which is within the range of normal prolactin levels, no stalk effect, normal thyroid function tests, normal sex hormones, and no IGF-1 elevation. And as predicted, the formal ophthalmological examination showed a red desaturation on the right eye. And there's a good app that you can download on your iPad to do so at the bedside. There was also a rapid afferent pupillary defect, relative afferent pupillary defect, which you can elicit with a swinging light test at the bedside. Then we did a formal visual field test, and the Humphrey visual field test showed clear decreased sensitivity in both inferior temporal quadrants, which argues in favor of a chiasma compression. So that is consistent with imaging. In synopsis, we have a symptomatic patient with a cellular lesion that is endocrine stable, but had visual field compromise. So what should we do next? Well, this is not an asymptomatic patient, so wait and observe is not an option. Here we can go for a surgical resection. We could do a biopsy and cyst aspiration or do primary radiation therapy, but that is no longer recommended. So I want to take you through this thinking. So there are controversies in surgery right from the beginning. Even Cushing called the craniopharyngioma the most forbidding of the intracranial tumors, and he had massive complications with this disease, largely because at that time, without imaging, they saw late-stage disease. But this didn't change over 80 years. Even Rutger, who was the chief editor of JNS, said that there's perhaps no other primary brain tumor that evokes more passion, emotion, and as a result, controversy than the craniopharyngioma. And that was just like a few years ago. So for more than 80 years, the question remained, what is the right surgical approach to deal with this disease? Aggressive resection or rather conservative management? Well, I can tell you from experience, resection is difficult, both because of the anatomy as well as because of the pathology. And Ramesh has talked about this. These are very sticky tumors that have sort of an unusual texture to it, and they seem to be almost like glue to the surrounding tissue. Also, the paracellular region is a delicate area. It's right adjacent to the optic pathways. It's next to the pituitary, which is affected. The hypothalamus, the circulus vessels, and the mammillary bodies can all be involved, which may influence, as we said, vision, hormones, mental status, as well as a number of other systems. As you can see from a cross-section, we can immediately think about open surgical approaches coming in from the front versus endonasal transsphenoidal approaches. Now, what are the best surgical options? When you go to the literature for open craniotomy, there's a plethora of options available, subfrontal, terional, frontolateral, everything is out there in the market, which tells you nobody has a good answer to this problem. The second thing you can learn here is that transnasal approaches are also available, which can be done microscopic transsphenoidally or entirely endoscopically. but you may need extended exposure and you may have to mobilize your pituitary. So I think approaches can and should be chosen based on the tumor location in relation to the pituitary stalk. And I really encourage you all to study your pre-surgical images very carefully. All my patients get a high resolution MRI scan in 3 planes, and get a DTI, and should get a CTA. And then we decide the tumors are either pre-infundibular, transinfundibular, or retroinfundibular, as seen in this color scheme. This was recently by Kasper published and retyped. So in the literature, you now find 4 types of tumor. Type 1 corresponds to the pre-infundibular tumor, where the pituitary stalk is pushed backwards and the chiasm is elevated. Type 3 is post-infundibular, where the pituitary stalk is pushed forward. Type 2 is inside the pituitary stalk, and type 4 is largely inside the ventricle. The next thing you really need to study is where's the chiasm? Is it directly in relation to the pituitary? Is the chiasm posterior, or is the chiasm anterior? And in a prefixed chiasm, you have very short optic nerves to mobilize. So here I just want to give the beginner 2 ideas. If you think about doing this openly, use an approach you are familiar with. And pterional approaches are exquisite because you have short working distances. It's very familiar to you from lots of other surgeries. You may have some difficulties with short optic nerves in a prefixed chiasm. You may occasionally have obstructive view in the optical carotid triangle from perforating arteries, but you can open up the lamina terminalis and look backwards. Transsphenoidal approaches are very nice because you come in at the axis of the tumor and chiasm, and you have excellent visibility under the optic nerve and chiasm, but you can only use it if everything else is elevated above, unless you are really experienced. What are the risks of surgery? Well, the risk depends on anatomy and experience, and it differs a lot in the native setting, first operation versus recurrent disease, pre or post radiation. I want to point out especially iatrogenic infarction is a major problem, as well as hemorrhage, hormonal disturbances, visual compromise, fluid leaks, all to be named. Cranial nerve palsies and anosmia has been described a lot, as well as seizures. But in my eyes, one of the biggest problems remains the high rate of incomplete resections. So what has helped in the past? Well, there are basically 2 schools of thought. The one comes out of Children's Hospital Boston that says, hey, gross total resection is the best for all patients. And then you save your radiation therapy for salvage, because recurrence seems to be pretty inevitable in this tumor, and radiation causes long-term problems, so you should delay radiation. The second school of thought comes from Washington. Subtotal resection is probably better, and the cyst decompression achieves a lot, but then you treat the tumor with radiation, and their argument is lower morbidity and higher quality of life. So just give you a summary slide right here before we go into details. The goal obviously is maximum tumor control at minimal morbidity. And in the community, results should achieve overall survival at 5 years greater than 90%, at 20 years, 60%. That means these patients are like a walking business card for you. If you do a great job, you will be praised. If you screw this one up for 20 years, they will tell, don't go to this hospital, don't be treated by this physician. So you want to be careful and do this well. Most patients present with significant endocrine function before and after. And one problem that is described in literature throughout is a recurrence rate of about 1/3 within 3 years from index surgery. So why does this happen? Nobody knows. Maybe we stimulate the tumor as we operate on it because it's not related to the mitotic index. The most relevant variables to make decisions are, what is the tumor configuration? What is the patient's age and comorbidities? And what is your own experience? And what does your center deal with well? So for open choices, you have a whole plethora of options. And there's an excellent chapter in Apuza's book from '93 summarizing all of this. And most of them focus around the frontolateral approach. But you can also go interhemispheric, and you can go OZ or transventricular. So I want to show you a good open series everybody should read about. Fahlbusch summarized an excellent series with fantastic follow-up in the 90s. They did 168 of these tumors with a mean follow-up greater than 5 years. And most of these patients were operated in an open way. Patients presented the typical way with largely visual dysfunction, more so in adults. And you can see that most of their patients undergoing transsphenoidal surgery had smaller tumors, whereas the tumors that were operated transcranially were largely larger tumors. What did they discover? In their 94 patients that were operated through an open approach, they only achieved about 50% of gross total resection in the hands of an excellent surgical department with good imaging capabilities. So that tells you this is difficult disease. Mortality was approximately 1% at the first operation, but 10% at recurrence. And the extent of resection was clearly related to size of the tumor, with gross total resection only being achieved in small tumors, 0% for tumors greater than 4 centimeters, which is stunning in someone who is experienced with this disease. What were predictors for subtotal resection? Especially invasion of the third ventricle, calcifications, and to be very adherent to the surrounding vessels, as Ramesh has pointed out. Now, a few years later, Falbusch moved to Sami's hospital in Hanover and followed up with a separate paper on only large tumors greater than 4 centimeters, again presenting with visual disturbance and hormonal dysregulation. The interesting point about this paper in JNS is that all patients had pre-surgical MRI with DTI. All of them were operated with intraoperative MRI guidance through the same approach, frontolateral, with opening of the lamina terminalis. What did they find? They only described the immediate outcome. Even large tumors, you can achieve about a 2/3 gross total resection rate, and you achieve still visual improvement in about 1/3 of patients, but at the expense of 50% additional endocrine deficits. How does this compare to modern endoscopic series? And this is not a bad series from Louisville, Kentucky in 2013, where they looked at 64 patients done in the MRI era. 47 of them were primary tumors. And here again, gross total or near total resection rate was approximately 2/3. So not significantly better than the open operation, no matter what they say. What is the outcome? Well, the first problem is that the mean outcome in most endoscopic series is relatively short, but they could show that endocrine status was affected 2/3 prior to surgery, and in another 50% of patients, post-operative DI occurred. And even when patients had no pre-surgical deficit, 50% of the patients showed a new onset post-operative DI. Vision improved in about 2/3 of patients, and again, 1/3 of patients had a clear recurrence within the observation period of 3 years. So that makes you equivalent between the two techniques available. In summary, craniopharyngiomas are suitable for endoscopic surgery, but should have clear features for this approach. They should be largely median, intracellular, largely subchiasmatic. It's better to do this on small to medium-sized lesions and not so many paracellular components. That makes it a lot easier. Now, then came an interesting paper in 2012 out of Miami. Komotar reviewed the world literature at this point and claimed a meta-analysis, and he looked at 3,500 patients and compared all comers of open surgeries versus transphrenoidal versus endoscopic. And in their abstract, they make a very bold statement. They claim they solved this problem. The gross total resection rate in endoscopy was higher than in open. Visual improvement was better in endoscopy than in open. Seizures were less in endoscopy than in open, and only CSF leak was a major problem at that time in the endoscopic literature, not so much in the open. So this looks pretty fantastic at a first glance, but I knew the literature and I also knew actually this disease. I had this done quite a bit, and I thought like something is wrong with this paper. I need to understand how they come up with this. So I pulled all 88 studies and looked at them in detail. And then you realize out of the 3,500 patients they analyzed, 90% of them were operated on through an open approach, and they lumped together all types, whereas only 5% of patients were operated on endoscopically. The open approaches had a mean follow-up of 5 years. The endoscopic approaches had a mean follow-up of 2 years. So the first problem is that your mean time to follow-up in endoscopy was not even the time to recurrence, which biases your results to looking too good. In addition, there was a selection bias because in most series, patients treated with open surgery had larger tumors than the transphrenoidal group. And that really tells you there's a completely different thinking process of how you approach disease. So patients treated with transphrenoidal or endoscopy had greater rates of visual compromise earlier because a smaller tumor in the cella expanding a little bit presses on the optic nerve much earlier. And because it's smaller, it's much easier to get more of it out. So if you read this really carefully, I think the conclusions were not defendable. there's no clear advantage of any approach, except maybe that vision is noticeably better with endoscopic surgery if the tumor suits it. So I think you need all tools in the toolbox, especially when you start your career and make good decisions. So I want to show you a few cases from my practice. This was a type 1 lesion that came through my pituitary conference to me with a preoperative scan showing a contrast-enhancing solid tumor entirely intracellular. And because it's intracellular location type 1, it can be taken out really well transsphenoidally, and I was able to get this out. Here's the optic nerve afterwards, nicely differentiated, and here's the pituitary stalk separated out without complication. This was a type 3 tumor, so post-infundibular. Although it looks intracellular, tiny as well, you see, oops, the pituitary stalk is again located just anterior superior, and there's a septation in the tumor. So I didn't want to do this transsphenoidally because I was worried I would either destroy the pituitary or sacrifice the stalk. And I decided to go in from frontotemporal, do it laterally, open minimal approach. And I was able to chisel this out in a nice way without complications. This is a case similar to our index case where you see a type 2 tumor that is partially cystic, partially solid. The tumor has a densely adherent portion to the pituitary and to the optic chiasm. So we did this open and the tumor was removed because we could separate it from the optic chiasm. If you come in from the right side, you can create a cyst decompression first that gives you huge working space and allows you a better dissection. I want to mention briefly what Cleveland Clinics has championed, which is a minimal invasive approach to all of this. And I tried this in a colleague of mine who came in and said, you know, I've read all the literature. I do not want to have an open operation for craniopharyngioma. I'm scared of the side effects. So with this scan, the patient came in with the cystic and solid tumor. He asked us to do a cyst aspiration with a stereotactic technique, which we did in a biopsy confirming craniopharyngioma. Then we radiated this tumor with stereotactic radiosurgery. The patient went back to work a day later after treatment. Continued to work as a physician. When he came back 6 months later, you see on the lower panel, there was a second operation done where we placed a catheter into the tumor cyst, draining the cyst into a Ommaya reservoir. So this patient got away with 2 minimal invasive surgeries, stereotactic radiosurgery, no comorbidity, and could continue to work as a physician, knowing that at 75, he just wanted to achieve 10-year control rates with radiation. So what did we decide on our index patient that I showed you initially? This is a type 4 tumor that is largely supra-intrainfundibular and also in the third ventricle. So I decided to do this openly. I always get pre-surgical CTs, and you can see there's a nice window to get in here. There's no vessel on the top. The lesion is largely at the bottom, and coming in again under the tumor, we were able to do an excellent resection, including half of the cyst wall, but we could not separate out the tumor being attached with the same vessels to the backside of the chiasm. So I decided deliberately to leave a small tumor remnant right there and to treat this afterwards. What is the next step, you may ask? And here you have to know a little bit the literature on radiation. I just want to show you quickly how this works. So we have lots of tools available in the radiation box. You don't need to know all the details here, but you need to know 2 studies, I think, that tell you the story. This is one out of UCSF 2010, systematic meta-analysis, where the group looked at the literature. They pulled 400 studies with at least 5 years of follow-up to look at control rates. And they said, we want to compare surgery alone to patients that had surgery followed by any type of radiation. And then they did a very nice grouping analysis. They grouped the patients with mean age and same tumor sizes and compared gross total resection alone to subtotal resection alone versus subtotal resection and radiation, and also gross total resection. This is what they found. In terms of overall survival, surgery alone is doing a fine job. Patients live for many, many years, 10 years.
1 minute left, sorry.
Yeah, I'm almost done. Subtotal resection is less of an issue. The patients do rather well. If you add in radiation, you get an insignificant difference between the 2 groups. When you do a subtotal resection, patient has earlier failure. So progression-free survival in subtotal resection is significantly less than in gross total resection. But if you add in subtotal resection plus radiation, you negate the statistical significance. So what you can show is that gentle subtotal resection is equally effective, if not better, than gross total resection if followed by radiation. The same group followed up with one more study showing that subtotal resection has a significantly lower rate in diabetes insipidus, which helps you to manage your post-surgical complications. And they also looked at a study that I pulled here showing you when to do the radiation. Radiation should not be done immediately after surgery, but at recurrence, because you defer your morbidity to a later stage and helps you to get the patient longer into better shape. So what type of radiation should we give? Currently, the standard of care is 3D conformal IMRT, which we did in our patient. There are only two things you need to watch out for. Enlargement of the tumor cyst can still happen after radiation in 10 to 20%, and about 30% of patients get pituitary dysfunction. So your endocrinologist must follow these patients really, really closely. We did the same thing for our patient. The patient did great for the next 6 months, resumed teaching. At 6 months, she came back exactly with this problem. Routine pickup, the cyst had re-enlarged and showed a significant compression of the third ventricle, although no symptoms. We went in and basically decompressed that cyst. On that day, the endoscope didn't work. Today, I would do this endoscopically. We did, in this case, an open resection of the cyst and did a fenestration of the ventricle to the basilar cisterns. And on the DWI in the right lower corner, you see that there was no stroke associated. So what have we learned from all this? Key to progression-free survival remains to control tumor growth via gentle conservative surgery in combination with radiation, which can be given at salvage. Treatment-related complications really define here the quality of life and overall survival. The 10-year overall survival is above 80% at this point, and that's why this is benign disease. You need to treat it benignly. So we need to think about smart surgery and limited morbidity for quality of life as much as dealing with survival. Thank you very much.
Thank you. Thank you so much, Ek. Sorry to interrupt you because we had a tight schedule. We have many questions for you. Seriously, most of them you already answered. And let me ask you something very, very brief answer. Someone is asking about the app you showed to check the That's the shortest answer I can choose for you.
I need to Google it. I don't have the link with me right now, but there are multiple apps available for your iPad. You can find this. Okay. Anyway, you have many questions now in Q&A. So if you don't mind, could you take care of that so we can keep going with the show? Thank you so much. Great pleasure to have you on board. Thank you for your contribution. Sure.